for joining today. Thanks, Dr. Seetharam. I think there was some problem in the visibility. Yeah, thank you.
Yeah.
The purpose of this talk, conversation is essentially to have your insights and understanding on the health and sanitation impacts, because this is one issue which has been important for several years. And there are very few Indian contextual level medical studies or expertise, although several are needed, but not in the recent context. So before we get into that, I would just like you to please introduce your work you have done, and then we'll get into this.
Sure. Thank you very much, Depinder. It's a pleasure to be part of this. I hope I'm audible. There was a bit of a break in the voice when you were speaking, so I hope it's rectified by now.
Yeah, it is.
Yeah, fine. So I'm Dr. Seetharam, and I'm trained as an orthopedic surgeon. So though I'm a trained clinician by practice and maybe by passion as well, I'm more into community issues, more of a public health guy. And going beyond that, probably I describe myself as a person involved in overall development with participatory processes and such stuff. So I often find myself a bit of a outlier in many contexts, given that my clinical orthopedic training in the views of many people limits me to certain contexts and certain areas, but I seem to be roaming around in a much broader arena. And that is very important because I had a pretty early start in this type of work because I've been associated with an organization called Swami Vivekananda Youth Movement, which we formed as students in Mysore Medical College. And through that platform, we have been working in the tribal rural backlands of Mysore. And from there, we have gradually expanded our area of work to cover the entire state of Karnataka. We entered that community more as clinicians, more as doctors, because that's what we were trained to do in our medical school. But once we went into the community, we learned lessons that community taught us much better than the colleges ever could. And these included issues around health beyond just medicine. We realized that medical work is different from health work. And health is a much more far-reaching, domain. And gradually, we explored and we learned that health, after all, is just one part of development. And that was the sort of evolution that we as individuals and even the cross-cutting sectors of development, including health, education, social empowerment, economic strengthening, and look at which would result in better quality of life. So that's how I've been engaging myself for the past nearly 30 odd years. Part of that, in fact, includes what is the of health, and so that brings me to the sector of WASH as well.
Okay. So, can you hear?
Yeah.
Yeah. So you've been a doctor since when, Seetharam? Since how many years now?
It's been maybe 30 years now. 1990 was when I completed, 84 when I joined. So 30 years of practice, predominantly in rural areas, but for a short period of time when I was away in Chandigarh for the post-graduation part. But then I've been back in the rural tribal belt of Mysore.
Okay.
Yeah.
So I have been working only in the natural resources and the WASH sector. And I have noticed this trend in the water and sanitation WASH sector a kind of a very narrow, prescriptive, kind of a restrictive kind of a trend of looking at hygiene and sanitation behaviors as something which are some quick wins where you can, just enter and change people's behaviors of hand washing or, using the toilets, and that will result in a significant improvement in their health outcomes. Whereas I do know that the health sector sees the things very differently. I think the health sector sees hygiene as related to people's lives, livelihoods, social status. So, for example, if a tribal, and I read this in those earlier seminal medical, paramedical books like Where There Is No Doctor, or one of my friends in the early 90s wrote this book called Taking Sides. Dr. Uh, these books actually were written in that sense. They try to understand why the poor, for example, don't brush their teeth, don't comb their hair, don't cut their nails, and it looked at their social context and their standing in the community rather than as a behavioral, individual behavioral issue. So, what do you have to say? Because you've seen now both the water sanitation side as well as the medical side. So, anything which you can share with us on this?
Yeah, many of the things that you mentioned actually are sort of social
Yeah.
norms. When people around, a person coming from so-called modern civilized setting looks around and sees people, he would expect that people have combed their hairs or trimmed their nails or dressed in a particular way. And that for that individual is what is normal and therefore the correct way of living. But then many of these norms are set in different ways in different contexts. Like for instance, when we first went into the tribal colonies, we would be the ones who would be outcast, because we would be wearing shirts and pants, and that was not acceptable in that particular setting. So the people have their own way of life, which has been sort of generational and has been fine-tuned by centuries of experience. And so they stick to certain ways of behavior. Now, this tendency to attribute certain gains to specific behavior is quite, like I mentioned, you wash your hands and trim your nails, and lo and behold, you are healthy. That tendency definitely exists, and one tends to create a hype around certain behavioral patterns and look at impacts and attribute impacts to certain behaviors. So in health and in disease, we generally don't look at one-on-one relationship like that. We always believe that diseases are multifactorial in its causation. So even if it is disease caused by a particular organism, the cause of the organism, the cause of the disease in a particular setting may be the organism, but what facilitates that particular organism to grow in me is important. And so when we try to understand disease and health in a scientific way, we see that there are very few conditions where this type of relationship. But on the other hand, we see a very intricate interplay of many factors. So if I wash my hands plus do a half a dozen other things, then I'm more likely to gain health and sustain my health. So that is something that as medical professionals and health practitioners, we always insist on. But at the same time, it's not a of intervention, because in this sort of a setting, a particular behavior has two types of impacts in time scale. There will always be an immediate gain, which is maybe not if you sustain it, then the likelihood of you gaining much bigger impact. So hand washing, if we take that as an example, has a limited immediate impact, and if you sustain it, it also gives for behaviors like hygiene behaviors or safe water and good nutrition contribute their part improvement. So we look at it multifactorial causation and multi-parametric involvement. Each one plays its role. So that way I would say provision has its role to play. Good nutrition also has its role to play. So when these are combined, then we can be more sure of sustained improvement in health.
Yeah, there was some problem in the connection. It was getting disconnected, but I hope it doesn't surface again. So just 2 more minutes I'll take on this topic on behavior change. And so, for example, now in water and sanitation, they are saying that knowledge is not equal to behavior change. And just knowing what is good, it doesn't translate into behavior change. But I think like in medicine or in public health, we already know that why a boy may not be, combing his hair. It may be because there is not a comb at home. It may be because the others don't comb at home, or it may be related to the fact that the hair get dirty very fast. So what is the point of, if you're living in a mud house, then you can't just look very spick and span for just for one event or one meeting. Similarly, about eating medicine. So it's not that they are ignorant or people don't know that they have to eat medicine. It's sometimes more related to what will I get out of it.
Yeah.
It won't. I may not live, or I may not get well, or I may be suspicious. So it's not that. It's just lack of knowledge. So unfortunately, in WASH, these questions are never asked, that why certain people are not behaving in that way. It is always assumed that it's a problem of communication, and we are not able to reach them, and we are not able to entice them sometimes, or we are not able to appeal to some of their instincts, and that is where we need to get into some kind of a sociological analysis, psychological analysis rather. So, okay, we can leave that topic and get into this health impacts. And Dr. Seetharam, I had shared with you some recent studies as well as one article by Wolf Peter Schmidt, in which he did an analysis of several studies of WASH impacts and health on health and WASH health and sanitation impacts. And it did actually a nice correlation of both methodological research as well as the impacts. And he came to a conclusion more or less that it's very difficult to prove an impact happening from research and trials, whether they are these RCT trials or they are the normal trials, to prove that one intervention has a certain kind of an impact. So, what do you think about this?
Yeah, that is very true. In fact, that's something along the lines that I just now shared, because each disease status or health status, has multiple variables influencing it. So, to be able to attribute a change in that status to just one intervention would be rather sometimes irrational and not very justifiable, because the same conditions may not be replicated elsewhere. So the contextual factors which are working probably in the tribal colonies that I stay in may be totally different from the urban setting of, let's say, Bangalore or Delhi. And so unless we take those factors also into consideration in our analysis, it would be very difficult to draw the black and white conclusions, very 100% this 100% that sort of conclusions. However, it is just possible to definitely get a idea that these are the factors which are influencing a particular state, and contextualize the interventions in that particular area so that those variables are taken into consideration, plus the intervention that we are trying to tweak can be adjusted to those particular conditions. So that is something that we have to remember, because many of these variables are beyond the scope of one sector. Like you mentioned, it could be social, it could be economic, it could be cultural or religious. So all these factors also have their role to play.
Yeah, you explained that. I'm sorry I had to make you repeat that. Okay, then coming to the straight point about relationship of child stunting with sanitation. So Dean Spears and others did a study, I think about 10 years back, and they came up with the conclusion. They're economists, so they studied Odisha and some other states, and they came up district-wide study they did, and district-wise they assessed the prevalence of stunting and the prevalence of toilets or the lack of toilets leading to open defecation, and they concluded that those districts where there was high open defecation were demonstrating high level of stunting, and therefore they made a further conclusion, or rather a deduction, that this was due to what was called a major cause of child stunting and anemia is environmental enteric dysfunction, EED. It is a
Yeah.
clinical disorder of small intestine which is virtually ubiquitous among the asymptomatic people living in low income settlements throughout the world. EED is characterized by increased permeability, which facilitates microbial translocation, etc. So,
Yeah,
what do you
yeah.
have about EED and sanitation and stunting?
About EED as such, or environmental enteropathy as it's often referred to, um, I think the scientific evidence in favor of this particular entity is yet to be conclusively provided. In the sense, the changes in the intestinal mucosa that is mentioned again are probably non-specific, and attributing it to lack of sanitation would be stretching it a bit, because again, like I was saying, the one-to-one connection between these factors would be difficult to establish. But having said that, what has been already known is that the absorption capacity of the intestines is varying in different individuals, and in community settings also there have been many observations where certain nutritional deficiencies exist. So that means that the ability of the child's intestine to absorb a particular nutrient could be affected because of certain environmental factors. Uh, and you were mentioning about deduction or an inference being drawn that a particular status is a result of another status. That sort of one-on-one direct links is where I am a bit wary of. Because again, being multifactorial in its causation, many of these states have very strong interplays. The way I understand it is something like this. When there is a total lack of certain things, and you start intervening with provision of those facilities, then you see a steep increase in the desired outcome. Now, like it's something like basic requirements and money. If you have money, you buy certain things. But beyond a particular stage, the more money you get, you cannot buy the more of the same thing. So you have a curve where water sanitation, etc., will definitely improve certain certain parameters like basic health or the intestinal infection rates being reduced, etc. But then that will sort of start plateauing off. So beyond that, maybe the interventions in one particular segment or sector may not continue to produce predictable incremental improvements in the status that's being observed. So while in settings where the situation of water and sanitation is extremely bad, and you have stunting and other components of malnutrition, intervention in water sanitation sector will definitely result in an improvement. But if it is an isolated intervention or investment in water sanitation alone, then the amount of improvement that you can gain will be smaller and shorter. You know, when we went into our tribal colonies as well, and we were working in the HD Kote block of Mysore district, we were faced with the same sort of situation where the water facilities at household level was virtually non-existent, and household toilets were really not heard of at all. You know, the entire block had a toilet coverage of less than 2%. So that was the status that we went into. So when the actual ground realities in terms of diseases that we would see would fit into the description of what were predominantly waterborne, you know, the diarrheas, the amoebiasis, and the issues related to personal hygiene like skin infections and scabies and such diseases. So at that point of time, the immediate requirement was to rectify the directly caused, discrepancies in health. So intervention with safe water and safe sanitation was the primary goal. So when we intervened with that, we could definitely see that the incidence of waterborne diseases went down, the diarrheal diseases went down, the diarrheal deaths went down. But after 20-30 years of our work there, and now the water supply system is significantly better. Sanitation coverage, though, I wouldn't want to touch any hornet's nest, but we are definitely not close enough to the 100% sanitation coverage that we want. But having said that, the difference that we can see is extremely from virtually zero to more than 70% coverage, and everybody generally practices good hygiene. But still, diarrheal diseases have not stopped. What has stopped, what has definitely reduced is the severe cases of diarrheal diseases that we would get. And for the past few years, we haven't had a diarrheal death in our hospital. The response time from the people is much better. So they seek health much better. So these are all the changes that we have seen. So in spite of ensuring safe water and safe sanitation, we continue to see certain cases of diarrheal diseases, and we have realized that it's probably not expected or possible to completely eradicate it. So they do continue, but the severity and the overall numbers have definitely come down. So in the same way, water and sanitation probably are the interventions which appear as sort of doable interventions in a given setting. So there has been a large amount of focus on providing water and sanitation. But like I said, after the initial big improvement that you see in health status after WASH improvements, there is a plateau that we reach, which again brings us back to the point that I was making, that water sanitation as isolated interventions can push health up only to that extent. So unless it's complemented with convergent interventions in other sectors, the further improvements would be difficult to get.
But Dr. Seetharam, don't you think that the initial gains of diarrhea reduction, especially in the Indian context, was more related to the water interventions, like in the 60s and maybe till the 80s? It was the ability of ours to provide hand pumps and safe groundwater, and that being a major cause for reduction in waterborne diseases, not sanitation, because sanitation, as you said, even now is not provided for. So sometimes, again, this whole emphasis that sanitation causes stunting is based on the premise that lack of sanitation should have caused stunting in Punjab, Haryana, Delhi, because these were areas also of open defecation till the 1970s, 80s. But we never saw stunting there. So this assumption that sanitation is causing it is also a little questionable. And I remember for example, in Rajasthan, when the water program came in the 70s, the first intervention it had was on filariasis, on that nadu worm entering your legs
Like,
because the well was open. So when they made a circle around the well, a 3 foot kind of a concrete, that reduced the contact of water with your feet because people didn't wear any footwear at that time, and that itself reduced that thing. So I think the earlier interventions were more towards water than for sanitation, which improved public health.
yeah, I agree with you, Depinder, but may not agree with you completely because of two reasons. One, yes, we did provide water, particularly groundwater in the form of tube wells, but my own personal experience of how well these tube wells function is not really something that I often enjoy, because pump as you may, you would hardly get any water, and that water would often be brown because of the rust and whatnot. So in my own colony, tribal colony where I was living, though there were 3 bore wells, this was way back in 1989, 1990, though there were 3 bore wells, none of them were functioning, and all of us, me included and the tribals included, we had to depend on the Kabini backwaters as the source of water. So we had to go back to the surface water because borewells wouldn't work. So coverage of safe water supply is a bit of a question mark, because at the implementation level it left some gaps. Now the other thing is equating sanitation to latrinization is something that I don't agree with, because often what we understand with sanitation is building a toilet next to the house and making sure that the person defecates in a pan in that small four-wall structure. Now, as a medical professional, I don't agree that that is sanitation. Sanitation goes much beyond that. So what in typically my own colony, my own experience used to happen was that the water sources that we would often go to would also be the places which we would all dirty up with various activities, including human excreta, passing human excreta. So invariably there would always be a gate open, an option open for the contaminants from human excreta, contaminants from animal excreta, and various other sources to get into either water or food or both. So with this bigger understanding of sanitation, we see that sanitation and water are very closely interlinked, and sanitation goes much beyond latrinization. So this is very important in the rural tribal context, and today we are talking of the ladder of safe sanitation, the ladder of safety. Often I get to hear certain definitions of open defecation and not open defecation or closed defecation. People naively think that if the person who is passing the excreta, passing the fecal matter, is in the open, then that is open defecation. If he is inside a closed building or a room, then that is safe defecation. Unfortunately, as medical professionals, we often say that the open or closed refers to the fecal matter that you have passed and not to you. So if the fecal matter that has been excreted out is covered and protected, then it is less likely to cause disease. But even if you have passed stools in a latrine, concrete structure, but if the stool matter is going into the open outside through a pipeline and getting into water line or whatever it is, or a water canal nearby, then that is still open defecation. So when we saw in our tribal areas, we saw that many times the tribals would go into the forest to pass stools and cover it up with some mud or something like that, with a handful of mud, and come back. So from a point of view of protecting the community from that fecal matter, that is still safe disposal. Whereas subsequently what would happen is that this place of passing stools would gradually come closer home, and when you do the same thing very close home, then the chances of it getting into getting mixed up with where you walk or where you get water from, where you play, etc. is much higher. So the risk of infection through feco-oral and other modalities is much higher. So that way, when we apply the bigger definition of sanitation and go beyond latrinization, we see that water, along with this expanded sanitation practices, together is what protects people from acquiring certain common infections. And the initial infection sets that we see in the lower socioeconomic groups are predominantly those which are caused by this sort of transmission. So we have the E. coli or the viral diarrheas, or sometimes even some form of fungal diarrhea, some fungal infections. So these are the more common conditions that we see in the lower socioeconomic communities. And so when these are corrected, that limited group of diseases will definitely be reduced. So that is something that I thought we should be clear about. One more point, very interesting point that you mentioned, was about the stunting and it not being very obvious in Punjab or Delhi or other places. When we first went into the tribal areas, we also would feel that a child is not growing well. When we would weigh the child, let's say an infant, mother has brought the infant and we put the child on a pan, and we see that the child has not grown. So we would get sort of worked up because we are applying the growth charts and the expected tables of a different community onto a different ethnic group. A typical Beta Kuruba, or the tribes that we work with, or a Jenu Kuruba, is not genetically or ethnically as tall as a person from, let's say, Bangalore, and much less compared to a person from Punjab or Haryana or Chandigarh. So unless we, that's what I was saying, unless we contextualize and look at coming up with growth tables for that particular community. A typical, a tall Beta Kuruba would perhaps be as tall as 5'4" or 5'3", and he's a well-grown, powerful, hard-working individual. So when compared to that sort of heights in the community, we have to see how the child is growing, and if that growth is commensurate with what is expected for that ethnic group, then I think the inferences that we draw would be significantly different, because then we wouldn't be comparing these growth rates to something that's beyond the context of these tribal groups. So that way it would be very important to look at multiple factors and then draw our conclusions.
No, thanks for clarifying that. I also missed that point, that actually sanitation mixing with water is the issue, not sanitation per se. And as you said, it's this reducing the distance between this water and sanitation from the jungle to the house now, and how safely the two are separated is what the sanitation challenge is, not just building a toilet and expecting that we have enclosed the shit in a toilet now, therefore it should be okay. So since the time is limited, I'll quickly get down to this EED part again. So what happened when this Shine trials came? They actually did a study on these two premises. One was that whether the cause of anemia and stunting is EED, and the second part was their premise was that the primary cause of EED is infant ingestion of fecal microbes due to living in conditions of poor quality and quantity of water, sanitation, and hygiene. So, whether EED is a result of fecal microbes being ingested in the system. So, the trials, when they were applied to WASH and EED, they came out negative. They said, well, we can't establish a correlation of EED actually happening with WASH. So, do you want to say something on this part as well?
Yeah, that's a very interesting finding, and in some ways it sort of sets a different tone and sings a different tune. Generally, what people are familiar with is one extreme viewpoint that with good water, good sanitation, everything will be great and hunky-dory and all diseases will be controlled. But this actually brings us back to certain realities which corroborate certain findings of some previous studies as well. Like I said, this EED or enteropathy as a distinctive clinical entity is not completely accepted by all clinicians and pediatricians, but some form of malabsorption in certain community settings have of course been observed and documented. Now, does WASH contribute to it? There have been, multiple findings, and in this particular situation, in this particular study, it's not showing any great relationship. But one factor that we will have to also remember is that for this malabsorption due to any enteropathic change, for that to happen, again there will be multiple factors that come into picture. And it also depends on the prevalent bacteriogram in that particular area. In some given conditions, in some areas, some bacteria are endemic. That is, they stay there and they multiply and they continue to spread from one to another, like organisms like Campylobacter, Jejuni, and certain other organisms. So it also depends on the organisms that are native to that particular community, which would be something that would affect the entire community there, going beyond just the few cohort groups that the study included. In the study that you mentioned, the SHINE study actually was not a enumerative community-based study, but more representative of the community. There were groups that had been identified, but these factors that exist in the community is uniform across all people, and so that would be equally affecting everybody. So an intervention in a particular group may not have a very significant impact in altering that commonality. So I think that is something that we will have to remember. And like I was saying, it's also true that some of these changes create an impact up to a particular level, and beyond that there is a plateauing off. And so it depends on the baseline situation prior to intervention across the entire community, and then we intervene and see if there has been any difference in the different groups, in the selected groups. The other factor that the SHINE study also talks about is the relationship to stunting. whether wash interventions and wash improvements impact the linear growth of infants and young children. Yeah. Now, this is also a very interesting finding. But what also is to be remembered is that this factor of stunting, this situation of stunting, is the end result of multiple factors. Now, what stunting basically means that over a period of time, the child has not grown as much as it should. And the maximum growth occurs in the first 2 years or 18 months of life. So 0 to 18 months is the maximum growth, 18 to 24 months. And then there is a slight lull in the growth. And then at around the age of 6 or 7, there's another growth spurt, which is called the juvenile growth spurt. And then around the adolescence, you have another growth spurt. So there are these 3 growth spurts. And the biggest growth spurt is the youngest age group, the 0 to 24-month age group. So in this study, they had observed the linear growth in children between 3 to 18 months. And they had seen that the difference in linear growth between those families where wash facilities were provided and those where wash was not provided was not great. So it's not a significant parameter which influences linear growth. I wouldn't fully agree with that inference, primarily because of the fact that the stunting itself is multifactorial. So wash is one of the factors that influences it, not the primary factor. So to say that because wash did not influence stunting, wash is not important. I'm looking at it from that point of view. Wash may not have influenced stunting, but that doesn't reduce the importance of wash. So that is one point that I would strongly try to make. And the other factor from the stunting point of view is that stunting is influenced by wash, but not the direct result of wash or lack of wash. In fact, the biggest cause for stunting, the attributable causes, when we look at stunting itself, many of the factors are intrauterine, that is maternal. Maternal malnutrition, maternal infections, and the growth in utero when the child is still in the uterus. So the inadequate growth during the uterine phase is the biggest predisposing factor for stunting. So that's what the research also said. Nearly 20 to 30% of causes are in utero causes. So wash is one of the factors which influences stunting. So I think from both points of view, I feel that polarity in terms of wash is not right, and stunting and wash are directly related is also probably to be questioned. So we need holistic intervention to combat stunting. Stunting is something that we need to look at and see what best can be done to prevent and ensure proper child growth. At the same time, we have to understand that wash has its importance and it has to be looked at in that context, not necessarily as the panacea for conditions like stunting. So it has its advantages and brings, yeah.
So I'll just quote from this other report, which was written by Oliver Cummings, and just the conclusion very sharply, it says, our view is that these new trials do not show that wash in general cannot influence child linear growth, but they do demonstrate that these specific interventions had no influence in settings where stunting remains an important public health challenge. So perhaps, like you are also saying, if those settings where stunting remains for various reasons a big public health challenge, there if you just go with wash, it may not make a difference. So when I first read it, I read it like I read English. So now when you explain like a medic. So then I can understand that, yes, So if there was a intra-uterus or fetal kind of a challenge, or if there were some other factors which are inhibiting. And of course, this study, SHINE study, also came up with the conclusion that if you link nutrition with wash, then it certainly makes a big difference.
Oh, yes.
So there was another part of the study which had breastfeeding and nutrition from 0 to 18 or 24. So there you could see a remarkable improvement in
Exactly.
stunting. So I think it should be read like this, that in general, you cannot say that it has no influence on child linear growth. Maybe not on stunting, but at least on linear growth, wash does matter. And in those areas where it is endemic, stunting is endemic for various reasons, there just bringing a wash intervention may not show results. So I think
Very
that's
true.
a good conclusion which Oliver drew. And initially I thought this was a little defensive, but or it was trying to take a way out. But I think it's a good conclusion to have. Yeah.
In fact, WHO has come up with certain guidelines on combating stunting, and in terms of its suggested strategies, recommended strategies, it has given out some 3 or 4 or 5 strategies, and the number one strategy is actually monitoring child growth and intervening with nutritional, corrections, including micronutrients which promote absorption. Even the EDD that we were talking about primarily is caused or precipitated by micronutrient deficiencies like zinc, etc. So if those are provided, then the absorptive capacity of the gut mucosa will be improved. So monitoring the children and ensuring that they get the right nutrition is the number one intervention. Plus looking at maternal care and ensuring maternal health and maternal nutrition. And then comes addressing health determinants of health like water and sanitation. So if we look at it holistically and address the multiple factors which are causing stunting, then we see wash in the right perspective as one of the contributing factors, not taking away the importance of wash, but ensuring that it plays its role in a plethora of appropriately aimed interventions.
So that was very useful. Thank you, Dr. Seetharam. I had thought I would begin this interview by quoting that Socrates' famous quote that I know I don't know, or I know nothing. But I think
Yeah.
the more you discuss things seriously, you do come to know something. And in this case, even my confusion has been addressed to an extent. How to see this whole issue of stunting and wash. Anything else, if you would like to say as a closing remark, that would be most welcome.
Uh, yeah, just that the link between water, sanitation, and health is not often understood adequately by people. And I also see that health professionals tend to focus more on the more glamorous specialities in medicine, like even in orthopedics, focus more on replacements, joint replacements, or become a cardiologist and put in stents, etc. But I think in terms of creating the right sort of impacts, the health department, health professionals also need to look at what determines health and what sustains health for people. And if we have this sort of dialogues, this sort of discussions, and involve more of the health professionals as well, I'm sure there will be a more convergent action. In addition to the curative interventions which have tremendous gains. One of the important reasons why diarrheal deaths have come down is the fact that the right sort of treatment is reaching people at the right time. So it's not to reduce the importance of curative work, but at the same time to make sure that that health that is gained is sustained. We need to make sure that they don't fall into the same trap by providing water, sanitation, nutrition, etc., etc. So this sort of a convergent approach where more people come, discuss, contribute would definitely be the way forward. Thank
And
you.
looking at water sanitation as a public good, finally, not as a service to be paid for. And
Yeah. Oh yes. Oh yes. That's right. That's right.
so thank you, Dr. Seetharam. so much.
Thank
Thank you
you.
so much.
Thank you. It was a pleasure. Yeah.
Bye.